we're a nerve clinic, right? We go to the spine, we affect the nerves, patients get better. With the Neubie, we identify the neural structures that are involved. We'll go and we'll place those pads specifically, for example, over the common peroneal nerve. We'll put one on the fibular head, and then we'll put one in the deep branch of the fibular nerve across the dorsum of the foot.
I'm Garrett Salpeter, and I believe that the most powerful and transformative way to help people recover from pain and injury, heal from trauma, and reach their highest levels of fitness and performance is to focus on the nervous system. In this podcast, we'll share knowledge from the frontiers of neuroscience and inspirational stories of how applying that knowledge has empowered people from all walks of life to heal, adapt, and grow.
Hello, NeuFit Nation. Welcome back to the Undercurrent podcast. I am delighted to introduce you to our guest today, Dr. Dan Neff. Dan is a brilliant physical therapist, one of the people that I look to for clinical questions. He's the founder of Neff Physical Therapy in Pennsylvania and also Breakthrough Manual Therapy, with whom he travels around the country teaching manual therapy techniques to hundreds of other therapists, probably thousands by now at this point. And in addition to being a respected educator and clinician, he's just a great guy. I've really enjoyed getting to know him over the last several years, and really excited to have you on the show. Dan, thanks for joining us.
Thank you, Garrett. It's always a pleasure to be in your company. Well, thank you for having me.
I'm honored by that, and I would love to let our listeners get a chance to know you. So can you start, please, by telling us a little bit about your origin story and how you got into physical therapy in the first place?
I kind of took the long route. I started out thinking that my career was going to be in wrestling. So wrestled, through junior high, high school, college. Then went on to coach, get my master's degree. And I ended up moving to Iowa, coaching out there for 4 years, trying to make a world team, Olympic team, and just didn't happen for me. So by that time, I had 2 small children and a wife that was somewhat homesick for her twins. So I decided to move back, and I started to work in the medical field, trying to find a job where I could support my family. And I came to realize that it was a time when there was very few physical therapists. There was a lull in the amount that we were producing. We had a deficit. So I was like, hey, I like this field. I had shadowed before. I was working at a orthopedic group. And I'm like, I'm going back to school. So I went back, got my DPT. Interesting story. So I guess before I went back, I kind of made partners with a local physician. And during that time, we had a great business, PT business. And then I decided to go back and get my DPT. And during that time, once I graduated, I realized that physicians and DPTs, really, it was not the most ethical situation to be partnered together. So we were having an example. We had a therapist in one of our clinics who, essentially was against the culture that we were trying to make at that time, and wasn't putting his hands on people, patients. Some patients were getting better, but we weren't having significantly great outcomes. But yet we were continuing, because of the relationship with the physician, to send patients to that clinic. So at that time, I just essentially cut all ties and said, you know what, like, if you want to send patients to me because we get good outcomes, great, but I don't think this is the most ethical thing to do. So we parted ways, and that's how Neff Physical Therapy got started.
I know you are a very high integrity person, so I'm not surprised to hear that is one of the themes going that early in your origin story there. And so you have 4 locations now. The original one is Quarryville, Pennsylvania, right?
Yep.
So
Amish country.
So when you were, you said your wife was homesick, you're going back home. So that's where y'all are from, right? I mean, you started off in the community there.
Yeah, so our first clinic was in the community that I grew up in. So, I had the luxury of everybody kind of knowing me and, uh, knowing my background. So it wasn't hard once we started showing the community what we could do as far as outcomes to get the community involved. And it progressed from there.
That's awesome. That's cool. So the transitioning here, one of the things that you're best known for nationally is teaching manual therapy. So can you talk about how you got interested in these particular manual techniques, and then of course we'll dive into the nuts and bolts of what you're teaching and what you're doing there. But can you kind of share the next chapter in that origin story?
Yeah, so when I finished up DPT school, essentially I came down, and Coreyville is a very small community. It was just me practicing. My wife was at our front desk at that time, and I had one assistant. And essentially, uh, going back to my community, I was like, I have got to get these patients better. So some of the things I just wasn't happy with the outcomes that we were having. There were some difficult patients that it just didn't seem like we were changing their pain and healing their condition. So essentially, I got blessed with a system that essentially shows how to place a high velocity, low amplitude thrust into a patient to change that patient's pain immediately. So essentially, I just started looking at the biomechanical, like the neurophysiological components of pain, and trying to figure out like why does this happen and how can we affect it. So from that, I just started experimenting. I would trace that uh, trace that or the origin of the patient's pain back to the spine, look at the level it came from, and then affect the nerve that was coming from there, and then patients just started getting better. Um, so we would, for example, patient with carpal tunnel, we'd manipulate the radiocarpal joint. If that didn't work, then we'd go up to the, humeral ulnar joint at the elbow. We'd go up to the cervical spine. And I would say to the patient, like 0 to 10, how did that feel? Like, did it change your pain? And if it didn't, I threw it out. If it did, then it went into the system. So over a long period of time, these mobilizations, these manipulations, just in experimenting, kind of build up overall, and we just started getting these like tremendous results where we were healing, the majority of the people that were coming into our clinic, and sometimes with some severe neurological problems.
There's a lot of parts of that I want to dive into. First, the way you said you were sort of exposed to this high velocity, low amplitude, adjustment or manipulation technique. I don't mean to use those words interchangeably, but it slipped out there. It sounds like it sort of came to you in a dream, or there's like some guru wandering by in a robe that sort of told you that wow. What is it? Something that you were reading about in old textbooks, or what sort of what inspired the idea to try these types of techniques in the first place?
So, yeah, that's a really good question. So, when I graduated from DPT school, my last clinical rotation was at Madden Physical Therapy with amazing Chad Madden, and I give him a lot of credit into introducing me to hands-on treatment of the spine. Um, a lot of that stuff was some higher type manipulations, and I just uh, I wanted to find a different way to do it. It was so essentially what happened was I was like, okay, this patient's neck hurts. So why are we just cracking their neck? Like there has to be a reason why we're doing that. And that's where that biomechanical and neurophysiological tracing came into play. So when I say, yeah, it wasn't some guru, I truly believe I got some blessings from above to be able to open my mind and figure some of this stuff out. But yeah, Chad introduced me to all this, and they have an amazing facility, amazing manual facility. I just wanted to understand why we were doing things. And from that, the system that we developed in Quarryville, Pennsylvania, evolved from that.
That's awesome. Chad, of course, many people listening to this know Chad or know of Chad. His partner in breakthrough physical therapy marketing, which I guess is it fair to call them sister businesses, Breakthrough Manual Therapy and Breakthrough Marketing.
That's fair.
So his partner Carl Mattiola has been on this podcast before, talking about strategies for marketing directly to patients. So just to fill in a little bit of context, and that was back early in the first 20 or 30 episodes. So good one to go back and listen to. I'd love to dive into this philosophy. So you already talked about that example. If a patient presents with carpal tunnel, you're going to work at the wrist, further up the chain, and then go up to the cervical spine. So can you talk a little bit about your treatment philosophy? Tell us more about that. I mean, you mentioned, of course, treating at the spinal level of the relevant nerve root there in the cervical spine, or if it's lower extremity in the lumbar spine. So can you say a little more about sort of the framework and the philosophy that you're using when you teach these methods to others?
Yep. Yep. So essentially, our treatment system is based off of what we call the restriction-based approach. So we found a unique way of identifying where the patient's symptoms are coming from. So we have an evaluation technique, not only just a clarifying exam, but we have an evaluation technique where we go through the spine and we figure out uniquely where this patient's pain is originating from. And then what we do is we impart what we call a therapeutic nudge. So, when I came out of school, we learned these, grade 1 to grade 4 mobs, and they just weren't changing the neurophysiological properties enough to change the spasm, change the neurotropic factors that occur in healing. So I started to develop the system of a therapeutic nudge. So we figure out which segment in the spine is restricted, and then we go and we put a therapeutic nudge, meaning that it is a high velocity, but it's very low amplitude overall. So what we're trying to do, Garrett, is we're trying to elicit these 1A fibers, these proprioceptive fibers, then that go back to the spinal cord, go up the spinal cord, go to the pain inhibition centers like the periaqueductal gray, the rostroventral medial medulla. And then they send inhibiting responses down the spinal cord that occur at the synaptic level, and then the pain responses stop immediately. So the patients that we work on and the system that we develop doesn't change patients' pain in a couple days. It's immediate. These patients feel better immediately. So we just incorporated this technique of figuring out where the restricted segments are in the spine, and then we essentially teach everyone how to impart a therapeutic nudge, but grade 5. But we're not jumping off the top rope on people. We're getting to the end range, and then we're moving that segment. And then we're reassessing, did we move it enough? And this always gauges our force. It gauges where we go next. So it's not just, we don't just teach, certain mobilizations. We teach a system of how to look at a patient and how to figure out these difficult cases.
So I want to dive into this a little deeper. There's some really powerful statements that you made there. I want to come back to this question. We're going to put a pin in this topic of talking about when does working with the spine have a greater impact versus working more in the periphery? And ultimately, in many cases, as we've talked about, you're going to be doing both. But let's go back into this. So one of the things that you said there is, you talk about these manipulations stimulating 1A sensory afferent fibers, and how that input into the spinal cord and brain, how that creates, a positive cascade, changing outputs, including inhibition of pain. So there's that, which you described beautifully. Is it possible to distinguish how much of the change is due to that type of input versus a mechanical freeing up of tissues, if there's any sort of impingement or entrapment, and then also, not to overcomplicate and bring up too many things at once, but I also would be curious to know, because a lot of people, when they think of spinal manipulation, are going to think of chiropractic adjustments. So I want to talk about some of the differences, because I think what you're describing here, there's certainly overlap in what's happening when you're doing spinal manipulation, whether it's a high amplitude or low amplitude. There's going to be some overlap, but I also think there's going to be a little bit of some differences in the philosophy and the framework as you're describing too. So perhaps we can touch on that. But I think that's sort of my first question here is, I love that input-based approach that you're taking, because it's so congruent with what we talk about with the NeuFit method, about providing input typically more peripherally, but providing an input into the nervous system in order to downregulate the perception of threat, or help the brain nervous system downregulate the various protective and compensatory movement patterns, and changing the input can change that output. So I really like that. So all right, narrow it down to that first question there of, how much do you think of it as that
periphery
change of input versus actually like a mechanical change in something more structural, related to impingement, entrapment, etc.
It's fair. So when we talk about working in the periphery, right? I said this the other day we had a student finishing up her doctoral work, and essentially I said to her, she was talking about soft tissue mobilization. I don't see you guys doing soft tissue mobilization. So I said, there are times that we do that, and I'm not going to get into that. But I said, do you know how many times that I did a trigger point release on a patient this year? I was like, 0, right? Because let's look at the physiological happenings that happens in muscle contraction and spasm, right? So the muscle goes into spasm, right, because of a neural input that continues to summate at that level, right? The muscle doesn't have the ability to go into contraction on its own. It has to take, the neural impulse comes down the axon, right, goes to the synaptic junction, all of those things, right? The acetylcholine go across, right, changes the chemical nature on the other side, the muscle contracts, right? But if that neural structure is irritated, so let's say you're getting cramping in like your extensor mass, right? If that neural structure is irritated at the C6, 7 level, you're going to continue to get that cramping, that spasm in that region until you change this. Yes, I can go in there and break my thumb and do a trigger point release, but I am not going to change it for a long period of time. I can get that muscle to calm down, but I'm doing nothing for the root cause of the problem. So I do think that in whatever level it may be, we do therapeutic nudges at the radiocarpal joint, at the humeral ulnar joint, at the glenohumeral joint, cervical spine, wherever it is, as long as you're stimulating those 1A fibers, that creates, as you put it, that cascade of inhibition that goes back to the muscle. I can't tell you how many times, a patient has an erector spinae spasm in their lumbar spine. I'll go in And again, I'll answer that question about chiropractic care in a second, but I'll go in and do some therapeutic mobilizations, manipulations at the level that's restricted. I can't get that patient back on their belly quick enough to be able to palpate that erector spinae and say that spasm is gone. Like, that's how fast the neural system works. It's immediate. And I have patients that come in that saying like I've had that spasm for 10 years. Like, and immediately it's gone once you stimulate the appropriate area and get that inhibition going. But they get, and I'm not saying soft tissue mobilization is bad in any way. It's just not how we choose to practice overall.
And in terms of choosing to practice, choosing to intervene somewhere, I like that you are going upstream and getting as close as we can, neuromuscular system wise, as close as possible to the root cause. No pun intended with the nerve root, but sometimes it's it's a good overlap actually in the naming there. But if you can go upstream and make a change very quickly, like we see. I was just at a couple conferences, since we last saw each other, and in 5 minutes, people who think they have an AC joint or a herniated disc or something like that, and they very well may, but we see increased range of motion, reductions in pain in a 5-minute demo at a booth, and it's like, well, what happened? Did the disc herniation, that extruded material go back into the disc in 5 minutes? No, right? It's the neurological response. So trying to go upstream and figure out what is really the source of the problem. So I love that philosophy. And I think you were about to talk about some of the differences between what you're doing and chiropractic and helping to clarify that. Is that where you were going?
So if I can real quick, I just want to make this point, especially about the Neubie. And this is one of the reasons why we like the Neubie, because it's involving the neuromuscular, central nervous system, peripheral nervous system, right? It's essentially the same principle. So, in school, we got taught that the cervical complex and the lumbar plexus, like those two plexuses are essentially operate independently, right? That if someone has, numbness and tingling in their leg, there's no way that it can be, caused by a cervical plexus or root level problem, right? That they're completely independent. Well, I can tell you that they're not. Like, if we know in, like, for example, rotator cuff surgery, within 2 weeks, 1 to 2 weeks of someone having a large tear in the rotator cuff, we have fatty infiltration. Like, do you think if someone has a lumbar disc problem that's radiating pain into their leg, that somehow it doesn't change the way they walk? It doesn't then in turn change the way they turn their shoulders, they turn their neck. All of this stuff changes immediately as soon as some sort of insult occurs. So what we found, and I would encourage everybody listening to, like, don't just look at the plexus that it's coming from. Like, look above and below that. Right? That patient could have some sort of focal entrapment at their fibular head, right? You need to mobilize that joint. You need to look at where it's coming from the spine. In turn, if that patient is getting better and better, but they still have a 1 to 2 out level pain, like, go up the chain. It's probably something higher. If you've got all the restrictions out of the lower spine, the lesion and irritation is also happening above. So here's what I would challenge you with. So the next time that you guys do a treatment, let's say the patient has, like, cervical pain, right? Difficulty turning the neck. Go and put the Neubie on the peripheral nerves of the lower extremity and give them a treatment there. So ask that patient to turn your head. Does that hurt? Yes, that hurts right there. Okay, just remember that. We're going to come back to it, right? Go and treat their lower extremity. Put it on the tibial nerve. Put it on the peroneal nerve. Run them through a session, and then ask them to turn their head again. You're you're stimulating the central and peripheral nervous system, I guarantee it's going to be better.
I love that. That's what I'll be doing this afternoon.
Yeah.
Trying that out. Yeah, I like that. Beautifully said there. So I like a lot of the points you brought up. For the sake of closing that loop that we had opened up around describing the differences between what you're doing, with these types of spinal manipulations that we've been talking about here versus what people think of in chiropractic. Can you help us clarify that?
Yeah. So when I first started treating it, like for instance, cervical spine, and we'll do some higher level grade 5 thrust to the thoracic spine, to the lumbar spine, to the pelvis, but the cervical spine is a little different. I mean, we hear about these problems that occur every year with vertebral artery, dissections and problems with cervical manipulation. And I would lay that patient down, and I took courses. I mean, I need CEUs too, so I wanted to see what's out there. So I was like continuing ed junkie. I took all the high velocity chiropractic, PT manipulation courses, and I would lay that patient down and be like, please God, don't let anything happen. And I just didn't like it. So I think our benefit is, one, a systematic approach into figuring out where we're going to put this, impart this force to. And then secondly, it's essentially we're getting to the right point and we're nudging that in the cervical spine. We're nudging below, above, wherever we want to go. And then we're reassessing, did we change that spinal segment? If so, great, we're done. If not, then we need to impart a little bit more force to that segment. So it's a progressive tissue building thing, but we're not taking that patient to end range and, thrusting that patient at all. That's not what we're about.
And as you're describing this nudge there, and you use the terms high velocity, low amplitude, or high amplitude. So just to clarify for everyone, of course, velocity is how fast one is moving, and then the amplitude is the distance through which you're moving. So low amplitude, you might be moving literally just a couple millimeters, whereas high amplitude, you'd be thrusting much farther, right? So that just to make sure everyone understands, in case there's any open loops in any of the listeners' minds.
That's a great way to describe it. Thank you. Yes. So taking it to the physiological end range and nudging it with a high velocity but low amplitude maneuver. Yes. We're not taking it to end range and then thrusting it over a long segment. Like we've just found that our system, patients don't get sore from it. We have outcomes that, anecdotally have been very, very good. And that's one of the reasons why we want to share it. Like, I want physical therapy to be held in the highest regard in the medical community. And we've been blessed with this system to be able to, have patients kind of go out and scream our name, and our clinics are oversubscribed because of it. And I just want to share it with our colleagues and say, hey, like, I'm not saying this is the way you have to practice, but I'm going to show you this is what we do, and we have some pretty significant results. So just trying to elevate our practice and get us where I think we should be.
Thank you so much for listening to the Undercurrent podcast. If you're interested in learning more about how NeuFit and the Neubie can impact your life, please visit our website at www.neu.fit, that's neu.fit, so you can learn more about how it might integrate into your professional practice, how you can use it as a patient, and you can also connect with our team there.
One thing that comes to mind there when you talk about high amplitude versus low amplitude, or even spinal manipulation generally, is the question of how you would approach people who have hypermobility. So, there's many more people like me who are more stiff. But even I, as a more stiff person, ended up, through some of my misdirected mobility work over the years, created local hypermobility in my lumbar spine, whereas that needed to be more stiff, and I needed more mobility in my thoracic and my hips. So I'd be curious to hear your your take on how to approach someone who has hypermobility?
Yeah, there are certainly there's certainly some conditions that are prone to hypermobility. Down syndrome, some of the connective tissue disorders that patients come in with. They're essentially hypermobile in a lot of different joints, but they also have restrictions in their spine. And the way we evaluate the spine, I would tell you that I believe that if we sat down and we went through a spine together, the majority of people that saying that is a hypermobile segment, I would tell you that segment is probably moving, and that there are other segments surrounding that structure that are hypomobile that need to move so that segment stops taking all of the movement and becoming irritated and continuing that attenuation of signal to wherever it's signaling. So I believe that I'm not saying that there's not hypermobility, but even in those patients, we will get in there and figure out which are the hypomobile segments, and we'll mobilize those segments. So those patients get hands-on as well.
Mm-hmm. Yeah, that makes perfect sense. I think that's beautifully said, and that does address just because one is hypermobile somewhere, it doesn't mean that everything is hypermobile or everything is moving even appropriately. So that makes sense. Since you mentioned again how deficits in motion at specific spinal levels affects, creates inhibition or other patterns of spasticity or whatever it might be. Do you feel like there's, just to complete the picture of why spinal manipulation is so valuable? I know you've mentioned different efferent and afferent pathways. Is there any more to say on that, just to, close out to the degree that we can for this discussion, sort of close out that topic of why the central manipulations are so valuable and beneficial? I think you've done a good job of describing it. I just want to make sure we've gotten, squeezed all the juice out of that orange before we move on.
Yeah. So again, like when we look at the neurophysiological workings of our body, our brain and spinal cord, make up our central nervous system. We know that the majority of things get controlled either at the spinal cord or the brain level, right? So those peripheral nerves are and there can be peripheral, nerve disease. I'm certainly not saying that, but everything is controlled at the spine. So we go directly there first. I'm not saying we don't go to peripheral joint lobes, we do, but we trace the structure that is irritated back to the spine and go to the origin of where the control panel is. And that's why I think spinal, mobilization, manipulation, therapeutic nudge, again, not like high level jumping off the top rope on someone, is so effective in changing patients. And if I could just I think one of the things that I talk to my team about, and this is again what our philosophical approach is. I go on the internet, I look at the things that are out there as far as movement, some of the exercises that are being delivered in these podcasts and these YouTube videos, like they are so advanced. Even in what we give, every day in our clinics, right? If we're an exercise only based profession, I think that at some point we're going to be pushed out because of that. So to be able to heal patients with your hands, and when you can change that patient immediately on the very first visit they come in, like that patient is going to be yours for life. They're going to call you every single time they have pain, and they're going to call you first.
That's beautifully said. And you mentioned there, again, this notion of helping physical therapy elevate and be the highest regarded that, being held in the highest regard it can possibly be as a profession to help people with musculoskeletal complaints and issues. And part of how you're working at the top of your license and helping to elevate the field of physical therapy is your use of diagnostics. So, electrodiagnostics in your practice, musculoskeletal ultrasound. Can you talk a little bit about how you are working in diagnostics, and also talk about how you prioritize? Like you just said beautifully, that when you do these manipulation techniques and you help someone feel better in their first visit, they're going to be your patient for life because you've established that trust. When you heal somebody's pain, they immediately develop this bond, this trust for you, right? The speed of trust, a great book. The faster you can create results for somebody, the better. So can you talk about, one, how you implement diagnostics? Because that, I think, also creates trust. When someone has this sort of fear and ambiguity and questions about what's going on, you can give them that clarity. I think that is another way to create trust. And then can you talk about sort of what your, after diagnostics, what's your triage or your mental algorithm in terms of when do we pull out the various diagnostics? When do we go right to our manual techniques? Sort of what that process is like.
Yeah, that's a great question. Um, the APTA just endorsed the title primary care physical therapy for us to be able to use that. And I truly believe that is where we should be. We should be the first providers for musculoskeletal joint and nerve issues. Diagnostics helps us to definitively know what's wrong with that patient, right? It can tease out the origin of that patient's pain. So we use EMG as well as musculoskeletal ultrasound. So I'll give you a good example. Um, I had a patient who I just ultrasound his Achilles tendon 2 days ago, and the patient had a significantly large tear in his Achilles tendon. So, so do we send that patient immediately for surgery? No. Like looking at the evidence, that patient can still. He was 54 years old. Um, But what it does for our practice is allows us to make a referral, an appropriate referral, if that patient doesn't get better. So, as a primary care physical therapist, it is now our job to make appropriate referrals. So, if I know that that patient has an Achilles tear, a partial tear, if that patient doesn't get better in 6, 8 visits, I'm starting the process as a primary care provider to develop a relationship with a surgeon who repairs Achilles tendons to say, hey, look, Dr. So-and-so, I have this patient, he has a partial tear. I saw it on musculoskeletal ultrasound. Can you please look at him as a possible surgical candidate? Instead of keeping that patient for 30 visits where we can't, we're not going to palpate that tear, you know, and if the patient doesn't get better, we don't burn all of his, visits for the year. We're using healthcare dollars appropriately. That patient's going to come back to us anyway after surgery because we're the ones that diagnosed him. So I think diagnostics allows us to do that. Just another quick example. I had a patient 2 weeks ago coming in, right? We did our exam, Tennell's positive. We did our Durkin's test positive. We did our Fallon's test positive. It's like, oh, this patient has carpal tunnel. Well, they have numbness and tingling in these 3 fingers. Everything clinically makes sense, right? He's got median neuropathy across the wrist. Okay, but he also has neck pain. So he has numbness, tingling, weakness, right? So let's take a look at that. So it EMG'd him. He had a double crush syndrome. He had a C6 cervical radiculopathy, as well as median neuropathy across the wrist. So again, like I would argue that this proximal problem set him up that he didn't get the neural healing that he needed to in his median nerve distribution. Thus, he was a hand intensive guy. The neural structures just didn't heal the way that they are and caused a problem distally. So, so that changes the way we manage that patient, right? Like, I mean, if we're doing radiocarpal mobs like the whole time, if we don't go to a cervical spine, we are not like completely healing that patient, and he's going to go away from our clinic with a poor outcome. So diagnostics allows us to definitively see, what that the problem for that patient is, and the health of the nerve that's innervating those structures.
That's really beautifully said there. And it also ties in, of course, your spinal manipulation techniques and diagnostics there. So that's great. Can you talk a little bit about your approach with peripheral neuropathy, since that's something that we've collaborated on the neuropathy study and different protocols over the years. So can you talk a little bit about your sort of algorithm with diagnostics, central spinal manipulation, using the Neubie as I know you do? Can you talk about your framework for peripheral neuropathy?
Yeah, so it's really interesting. I mean, you know, uh, we were introduced to hands-on diagnostic um, probably 7 years ago now, and it's kind of completely changed the way we practice with EMG, musculoskeletal ultrasound. Those guys have an amazing educational platform. It's just kind of changed our practice overall, and honestly, our reputation in the community for being a one-stop shop to go in and get diagnosed what my problem is. But my point being is like things like peripheral neuropathy, things like ALS, things like myopathy, inclusion body myositis. Like these are things that we don't get in like PT school that we're now exposed to overall. So peripheral neuropathy was one. We talk about diabetic neuropathy, but dealing with peripheral neuropathy and doing these studies, like there's hundreds of reasons of why someone gets peripheral neuropathy, and if you can stop the insult as far as why those nerves are dying, the patient has a chance to heal. So diagnostics allows us to figure out not necessarily why, but we look at the comorbidities with that and often can figure out why the insult is. I mean, alcoholic axonal neuropathy is a real thing, so we talk to those patients about that as primary care providers. So what we've been doing is once we identify that it's truly a peripheral neuropathy, right? Someone has bilateral numbness and tingling on the plantar aspect of the feet, like it could be an S1. It could be some sort of, bilateral stenotic issue in someone. Usually these are older patients, right? That the S1 nerve root is being compressed on both sides. So we need to tease that out, and EMG helps us do that. It lets us see a global problem in that patient, right? All the nerves, polyneuropathy, right? All the nerves are being damaged. So when we see that, we put two things together, and we've been having some significant results with this. So essentially, we make sure proximally that the neural structures are getting the neural input that they need, and that's with our spinal mobilizations. We mobilize the pelvis. We make sure that the pelvis is symmetric. We go distally into the nerve joints. We go into the feet, mobilize all the joints, every single bone in the foot. But with that, we pair the Neubie. Do you want me to talk about how we do that? Because I think it's maybe a little bit different.
Yeah, I definitely do. First, can you talk about more specifically how you distinguish between like you talked about an S1 issue versus a peripheral neuropathy issue? What findings are you actually seeing on EMG and or nerve conduction velocity that are helping you distinguish?
Okay, good question. So So we know that in radiculopathy, right, the way our spinal system works is that the neuronal structure, the dorsal root ganglia, which is in charge of the sensory responses that are coming from the periphery up, is outside of the foramen. Okay, so in radiculopathy cases, all the sensory nerves are usually normal. Okay, in a peripheral neuropathy, though, we see a distal dying back of those nerves. So where our recording electrodes are, we'll see absent or diminished sensory responses. And when we see like the sural sensory is low and the velocity is slow, we see that the superficial peroneal sensory is low amplitude and slow. And then we see that these motor nerves, when we test them with nerve conduction studies, we see a global decrease in velocity. So then what we do is we go up to a hand, for example, and we look at and see, is this a systemic problem? So the patient has no symptoms in their hand, but yet when we look at the sensory nerves to the median nerve, we see that that amplitude is low and it's slow across their wrist. We look at the motor of the ulnar nerve, right? We see that that amplitude is low and the velocities are slow. So we know that this is a global problem. It's not just coming from, S1. So the other thing that we do is, we'll stick a small needle with EMG into that gastroc, right? S1 innervated. If that's abnormal, it still doesn't tell me that if it's peripheral neuropathy, because, right, that's a distal symmetric problem, right? But then I'll go up and I'll stick like, glute med or TFL. Those are both 5-1 innervated muscles. If they're abnormal, then I know it's coming from the lumbar spine because it's not a distal problem anymore. Those are proximal muscles that are abnormal, right? But if those are normal, then I know that it's the symmetric distal polyneuropathy.
Thank
And
you.
you can certainly have, both problems, and we find that, often. But that's how we essentially distinguish
Yeah.
quickly.
Thank you for that. I mean, having listened to this and talked through this before, it's not using EMG every day myself. It's still fun for me to dive in and hear it again and just get the sense of the clarity that you're able to provide in the diagnostic process doing this. So I really appreciate that description. And yes, now can you talk about, which you started to do before I sent us in a little bit of a adventure in the other direction. Talk about the ways that you're using the Neubie in this
Oh
context.
yeah, yeah. So it again, like just going back, like we're a nerve clinic, right? We go to the spine, we affect the nerves, patients get better. So with the Neubie, um, what we do is essentially we identify the neural structures that are involved. And in a polyneuropathy, it's like all the nerves of the lower extremity. But what we'll do is we'll go and we'll place those pads specifically, for example, over the common peroneal nerve. So we'll put one at I can't lift my leg up high enough to show you, but we'll put one on on the fibular head, and then we'll put one in the deep branch of the fibular nerve across the dorsum of the foot. We'll take the other set of pads. We'll put one in the popliteal fossa across the tibial nerve, and then we'll put one on the inside of the ankle of that patient to get the tibial nerve distally, and then we'll run them through essentially moving those structures so that the body can start to attenuate the pain. They can start to, get that function back and start changing those synaptic, as changing it at the synaptic level. So when we combine, and that's, yeah, I'm sorry, we're not doing the water bath. Well, but it's been so effective for us, like just targeting those neural structures. I can't tell you, combining the spinal manipulation with the Neubie, we've been having great results.
I love that. And on the topic of how you're using the Neubie, can you actually share a little bit about what you're doing on the business side? I know we've talked a little bit about what you do, how you do it in the first session. I think it's just brilliant. So I'd love for you to share that with everybody here.
So what was happening was we were like putting it on both legs, and the patient would come back, and in peripheral neuropathy, especially in cases that have significant dying back of those nerves, we're not like completely changing that patient to where they're well and healed the very first visit. It's just not going to happen, right? So they were coming back, it's like, I don't know if it's better or not. So we were like, all right, well, let's just put it on one leg. You got to be able to tell the difference between that. So we do our spinal manipulation techniques. We put the Neubie on just one leg, one extremity, and very few cases do we have come back that say, you know what, that say it's not better. Very rarely do we have that. Everybody's like, my right leg was so much better. Like, how do I sign up for this?
Nice. That's awesome. Yeah, that was brilliant. So thank you for sharing that.
Yeah.
And that is part clinical, but also part business strategy. So a good opportunity to segue into some of the business strategy. And one of the things that I would love to hear you share, Dan, for our listeners, is your approach to growing your business. You've mentioned that you have 4 locations now. I think we mentioned that you have 4 locations now. If we haven't, he has 4 locations. Of course, started with one that's grown over time, and the way that you combine your business growth with your staff development, I thought was brilliant. And so I would love it if you can share your strategy there with everyone listening.
So when I first moved to Coreyville, again, I took the long route around. So I think I was like 35 when I finished my DPT. So I was like, all right, this is it. Like, this is my hometown. Like, I got one clinic and I'm happy and I'm going to help the people. And then we started to realize that I started to get these young guys in, and they wanted practices of their own. And I was like, you know what? Like, I believe we're being called to like help more people. So how do we do this? How do we expand our practice and help more people in different communities? So essentially what I did was I set up this program where, we get a new therapist in. Essentially, they go through like a 16-week residency with us. We teach them all the spinal mobilization techniques, and they get introduced to our culture. From there, we do a 2-year program. If they want to progress into owning their own facility, we do a 2-year program where somewhat it was me, but now we have 4 clinics, so it's other practice owners as well in the Neff family. We will mentor them as far as spinal manipulation techniques go. So they get 2 years of spinal manipulation techniques, and then I sit down with them on a monthly basis, and we talk through business structure. We talk about what's important. And the majority of the time, honestly, Garrett, it's not this like, aha moment. It's about patient experience. When that patient is happy when they leave, the business takes care of itself. Now, there are numbers, there are taxes, there are insurances, all the business stuff, managing employees. We talk through all that stuff, but essentially it's a lot about the patient experience. And how do we do that? And it's not just the patient getting well, but there are a lot of things that go into that, to making sure that they understand that they had a good experience from the first time they walk in until follow-ups. We see our patients every 6 months. We try to act as a primary care. Hey, we haven't seen you in 6 months. I'd like you to get in. And for us to go over your spine and see what's going on. But we take that 2 year learning curve, and once they're at 2 years, then we'll go out and we'll figure out, especially if they're in a different hometown, they're from somewhere different, we'll put them in their hometown. So we'll figure out a building, we'll secure the building, we'll build it out, whatever we need to do, and then we bring that individual into the company.
Awesome. So there's an opportunity for the ones who desire to have, desire or aspire to be practice owners. They can still work with you, and you can have that opportunity for them to grow and still be part of the Neff family, the Neff business, as you said there.
Yep.
So I like that. Yeah, that's great. You got a great approach, my man, in business and clinical.
Blessings, brother.
I love it. I love it. So as we wind down here, let's see. Is there anything? I mean, as someone who literally travels around the country educating clinicians, is there anything more to say? In terms of the different methodology, clinical topics we've talked about. Is there anything more that you feel like we need to cover to complete that message?
I mean, I would just say, like, again, it certainly costs for us to come out, and, teach at a facility. But, it's not something that's outrageous. We don't retire off of this business. Sometimes we do it altruistically if we have to fly to California, like all of our profits are pretty much eaten up at that point. But we're doing this because we have been blessed with a system that's like really keeps all of our clinics oversubscribed. Like everyone practices this way, or you don't practice at Neff. It's just our culture that we're in, and we want to just share that with our colleagues. They're CEUs for the course. We can do it right in your facility. Come out. We train all of the patients, all of your practitioners. One of the coolest things that I get to see is when I walk into one of my clinics and it's 6 o'clock at night and all the beds are full and everybody's practicing the same way. Like, to get everybody on the same page, like I used to have problems where it was like, oh, I just want to see Dr. Neff. I just want to see Dr. Neff. Well, just try this practitioner. And then it's like, oh, it's the same. Like I'm fine. So it's allowed me freedom to get out of the clinic, as well as, if someone goes on vacation, it's not like they're going to get some sort of different treatment, philosophical approach. It's going to be the same. So we never have those problems of people going on vacation, or if I want to try to get out of the clinic to do more administrative stuff. Like, it's been an easy transition that way. So, if anybody's interested, they can reach out to me at neffpt.com, and we can talk through how maybe we can help you.
So that was going to be my next question, is how people can get in touch with you. So Neff PT, NEFF PT, as in physicaltherapy.com, is the website for your practice. And if people are interested in learning more about breakthrough manual therapy courses, should they reach out to you through the same Neff PT website?
Yeah, you can certainly reach out to me, and we can go from there.
Okay.
All of our courses are listed on the Breakthrough PT marketing site as well. So you can just kind of get an idea of what you're getting into.
And that is...
But it is a certified orthopedic manual therapy certification. So there is a comp certification at the end of it.
Awesome. Very good. So final question, Dan. If you could share one message with the whole world, if you could shout it from a mountaintop for everyone to hear or put it on a billboard for everyone to see, what would your message be?
I I think just keeping this in the family of physical therapy at this point, if all the physical therapists could hear me, I think that Dimi Kostopoulos said it really well at the last symposium. There are great results and there are greater results. We all think, that we have these amazing results and that we're all the best therapists. And PTs are amazing overall. I would just say to, keep an open mind. There are many different ways, and I'm continually taking courses to try to find different ways that we can help our patients. So just keep that in mind, keep an open mind. The other thing that I would say is, we need to embrace as a profession this primary care physical therapy title. Reach out to your Congress people, reach out to your state reps, tell them, but we can't be primary care if we don't have full direct access. Like, we have to be able to order imaging. That's a high level. I've been on my state rep in PA. We have to be able to do that. So we need, as a group, to really reach out. I mean, Utah just got it passed. They can order imaging now. They have full direct access. Like, that's how it's going to change. But, for us to be direct access, we need to really, not direct access, primary care, we really need to operate at a higher level. And we need to do it as a community. Not just a good clinic here, a good clinic there, but consistently across physical therapy. So, embrace this new title that we have and really try to reach out and try to change things. I've been trying to do that personally more to get involved.
I love that. I can't say it any better myself, so I won't even try. All I will say is thank you, Dan, not only for coming on the show here, but for all the amazing work that you're doing with your own patients. You're a true role model and leader, and also what you're doing to help lift up the profession, educate others. And I love how you're leading by example, constantly learning. One of my favorite sayings is the day we stop learning is the day we start dying. And you're on pace to live a long time, my friend. So thank you.
Thank you, Garrett. It's always a pleasure to see you and talk to you. You're so smart, and I appreciate all those great questions. Thank you.
Well, thank you, and I appreciate you and you, Dan, and you for listening to this episode of the Undercurrent podcast. So if you feel so inclined, please like, subscribe, share the show, and we will see you on the next episode. Goodbye.